Chapter 2. Assessment Principles and Risk Factors. Understanding and effectively assessing individuals who use drugs is a vital component of primary care. A robust and empathetic approach to assessment ensures that patients receive the most appropriate interventions, while minimizing risk and maximizing their potential for recovery. This chapter outlines the key principles of initial and ongoing assessment, explains why these are important, and uses a practical case study to demonstrate how a comprehensive and timely approach can significantly improve outcomes. Initial risk assessment, a holistic approach. When a person presents to primary care with a history or a suspicion of drug misuse, a full initial risk assessment must be conducted. The goal is not only to understand the extent of their substance use, but also to identify any immediate or long-term risks to their health, well-being, and safety. This assessment is both clinical and social in nature, covering the following key domains. 1. Substance use history, *, what substances are being used, frequency, quantity, and route of administration, * patterns of polydrug use, including alcohol and prescribed or over-the-counter medications, history of overdose or withdrawal episodes, dope, sexual and reproductive health, * risky sexual practices, and potential for sexually transmitted infections. Contraceptive use and pregnancy status, * history of sexual exploitation or trauma. 3. Injecting practices, whether the patient is injecting drugs, if so, what equipment is used, and whether it's shared knowledge and use of needle exchange programs, *. Evidence of injection site infections or venous damage for overdose risks. Prior overdose incidents, * knowledge and use of naloxone. Co-use of CNS depressants like alcohol or benzodiazepines. 5. Mental health assessment, *. Coexisting mental health conditions, suicidal ideation, or history of self-harm. Psychological readiness for change. 6. Social determinants of health, * housing status, stable. Temporary or homeless employment and income level, family dynamics and support systems. History of domestic violence or involvement with social services. This holistic view is essential for building a person-centered care plan that addresses the individual as a whole, rather than isolating substance use as a separate issue. Avoiding delays. The importance of early and ongoing assessment. Delayed assessment and treatment initiation can increase the risk of further harm, disengagement from services, and unnecessary suffering. Initial assessments should gather enough information to initiate a treatment plan, even if full details are not yet known. A phased approach is often more effective than waiting to complete a full assessment. For instance, where there is clear evidence of opioid dependence, opioid substitution therapy should not be delayed. Stabilizing someone on methadone or buprenorphine can reduce risk-taking behavior and provide a platform for further care planning. Assessment is not a one-time task. It must be seen as a dynamic process, revisited at regular intervals or when significant changes in the individual's life occur. Factors like relapse, pregnancy, housing instability, or the emergence of new mental health concerns can all necessitate reassessment and revision of the treatment plan. Case study. Darren. Darren is a 34-year-old man who presents to his GP practice requesting help to stop using heroin. He has been using heroin daily for over 10 years and also uses crack cocaine 2 or 3 times a week. He has injected both substances in the past but currently smokes them. Darren is unemployed, lives in temporary accommodation, and has lost contact with his family. He reports feeling anxious and depressed, but is not suicidal. He has previously overdosed twice, but has never been in structured treatment. The GP conducts a comprehensive assessment. Darren confirms he is not currently injecting, though he has poor venous access and a history of injecting-related infections. He reports that he sometimes drinks alcohol, but not regularly. He has not used any prescribed medications recently. Darren is sexually active, but inconsistent with condom use. He has never been tested for blood-borne viruses. Like hepatitis C or HIV, the GP offers him BBV testing and vaccinations for hepatitis B in terms of social factors. Darren expresses interest in reconnecting with his family, but fears stigma. He has little financial support and often misses meals. His accommodation is shared and unstable. Given Darren's history of regular opioid use, previous overdoses, and clear motivation to change, GP offers him a same-day prescription of methadone. This is paired with a care plan involving follow-up appointments, psychosocial interventions, BBV testing, and a referral to a local recovery support group. Key learning points from Darren's case: asterisk, an effective initial assessment includes not just drug use, but sexual health, mental well-being, and social stability. Darren's experience with overdose and his unstable housing increases vulnerability, reinforcing the urgency of intervention. Offering OST without delay, along with harm reduction measures, helps prevent further harm and promotes engagement. Ongoing support, including mental health review and social care involvement, is vital for sustained progress. Conclusion: assessment is the foundation of effective drug misuse management in primary care. It must be thorough, empathetic, and tailored to the individual's needs. Early and ongoing assessment ensures that treatment remains relevant, responsive, and impactful. By identifying risks and addressing them holistically, clinicians can make meaningful interventions that support recovery, protect health, and improve overall well-being.